It's important to understand what aortic valve bypass is, and it is an operation also known as apic-aortic conduit that involves the construction of a valved conduit from the apex of the left ventricle to the descending thoracic aorta. It's an operation that's been around for a long time. It was first performed clinically in the early 1960s and has a long track record.
I've been doing this operation for more than 30 years. And I've been doing it the same way that I started out doing it, using a metal cutting device for the LV apex, cutting out a plug of muscle, again using my thumb to occlude the hole while I grab the connector and exchange my thumb for the connector, and then tying the device there. So it's been around for a long time. It's a concept that's 100 years old.
There are some very common questions that we get asked, and people say, oh, gee whiz, you can't treat aortic stenosis by bypassing the blocked valve, you have to replace the valve. But in reality, we do an operation in the operating room every day called coronary bypass surgery, and we don't remove the obstruction in a stenotic coronary artery, we would bypass it. So this is, people will ask us, well, gee, what about blood flow to the brain? And we've shown that blood flow to the brain is normal after this operation. The distribution of blood flow coming out of the left ventricle is very predictable after aortic valve bypass surgery, with 1/3 of the blood flow going to the native, through the native aortic valve, and 2/3 through the conduit. We've learned that this operation is outstanding at relieving the left ventricular outflow tract obstruction associated with aortic stenosis. And patients feel better and do well after this operation.
If technology such as the Correx device to be successful, you have to have proper team collaboration. You have to have a collaborative team with leaders such as Dr. Gammy and Dr. Brown, who are experts in this field, who, based on their experience, this particular product was basically developed. And hence, to have them be your proctors and to provide you with the guidance in terms of doing the procedure is the best you want.
It really consists of the same components that are used by Jim and I today, except that the connection to the left ventricular apex is much safer for the patient, and there's a lot less blood loss, and it's safer because there's a lot less blood loss. And it's a very well controlled anastomosis, whereas coring a plug of muscle out freehand, taking the muscle out, putting your thumb in, and then putting the device in, always is associated with some excitement and some blood loss. Whereas using the Correx kit, the valve, the conduit is all together, and you're able to insert it into the left ventricular apex with minimal blood loss. And it's just a much more straightforward, less exciting way to do a left ventricular anastomosis.
Aortic valve bypass really consists of two anastomoses: the distal anastomosis between the valve conduit and the descending thoracic aorta, and the proximal anastomosis, where you place a rigid apical connector into the left ventricular apex. And the Correx kit facilitates, simplifies, and makes more reproducible that act of inserting the apical connector in.
Utilizing the Correx device, the reason this operation hasn't been that popular over the years is because it's pretty scary. Not many cardiac surgeons will want to cut a hole in a beating heart to be able to do it. And so it hasn't been terribly popular, but I think the Correx device will say this is nice and straightforward. Any well-trained cardiac surgeon can do this operation and will offer benefit to a group of patients that are now refused treatment for their aortic stenosis.
We know from the data that 30 to 60% of patients with symptomatic AS are never even referred for surgery because of the perception of high risk. So we think there's a lot of folks that will benefit from this.
2/3 of the patients that come to my attention are patients that have been turned down by other cardiac surgical centers, experienced cardiac surgical centers, and said this is just too high of a risk patient to warrant conventional aortic valve replacement.
The bulk of the patients that I've operated on is elderly patients who have high-risk characteristics, particularly those with porcelain ascending aortas, and those who are redos, those who have had prior coronary bypass surgery with patent grafts. Those would make up the bulk of the population that we have operated on.
This particular individual had so many factors that would make him a very high-risk candidate for conventional aortic surgery. Aortic valve surgery involves basically, first of all, utilization of the heart-lung machine, clamping the aorta, and having to do a sternotomy on him, or even not a sternotomy, any other exposure of his basically structure centrally. Now, because he's had a previous operation, he had a previous bypass surgery done in 1999, any type of reentry in his chest would pose some risks for him. In addition, his entire aorta was completely calcified. And we know that previously, when his aorta was manipulated during his bypass surgery, he had a stroke. So he had quite a significant stroke from which he has just recovered over the last 5 years. He's being able to resume back his normal activities. So to pose him to a conventional operation, you would make him being confronted with numerous risks. Risk of entering into a chest that's not a virgin chest, and during your entry you could injure his bypass vessels because he's got bypass vessels that are still working. In addition, he would be at risk of stroke if you put him into a conventional surgery where he would require manipulating his aorta and putting him on the heart-lung machine. So therefore, a conventional approach for him would be a very high risk of stroke in him, especially an individual who has had a previous stroke, and we know that his aorta is very diseased. So based on the two reasons, definitely conventional operation was not at all in any ways an option for him. And also an option of doing a transcatheter approach was not that best.
Now for this guy, well, he had a major stroke already last time. I mean, worst thing could happen to this guy is another stroke. Then will be life just not worth living anymore, right? If you get another stroke, I think this way we have we doing this way with the aortic valve conduit, we minimized risk of a stroke compared to transapical valve or trans-TAVI, whatever TAVI is, right? So it's add more safeguard to reduce the risk of stroke.
And the fact that it's a beating heart, I think there's some really critical advantages of aortic valve bypass surgery compared to conventional aortic valve replacement. And here they are. Number one, you're not on the heart-lung machine. Number two, you do not have any manipulation of the ascending aorta. So there's no aortic cannulation, there is no aortic cross-clamping, there is no aortotomy and debrinative valve. Number three, you don't stop the heart, so you don't have to worry about a hypertrophic AS heart not waking up after cardioplegia because the heart is beating the entire time. And number four, the operation is not a sternotomy.
The other approaches to these elderly group of patients are the transcatheter valves that are being introduced worldwide, and many have been done in Europe, and they're being introduced in Canada and now in the United States. And that operation, although it's effective in relieving aortic stenosis, there's a substantial risk of neurologic problems, or neurologic problems and heart block are the two most common complications, or problems with the entrance of their catheter into the vascular system, if it be the femoral artery or the left ventricular apex. Controlling those areas with that technology has been problematic. It's getting better as time goes on, but it is problematic. The aortic valve bypass, utilizing the Correx kit, eliminates the peripheral vascular problems. There's been no incidence of heart block, and there's been, to date, no incidence of stroke related to the surgery itself.
A conventional approach would have definitely been extremely high risk for him. A transcatheter approach would have been an option, but definitely not through his peripheral vessels, not through his femoral arteries, because of the fact that his femoral arteries were extremely calcified, along with iliac arteries. He could have had it done through his apex, the transapical approach, but again, you're dealing with wires going up in aorta that's diseased, and potentially that could cause, again, embolization of some calcified plaque, and again, that would pose some kind of a stroke again for him. So this modality of treatment for his severe aortic stenosis was probably the safest approach for him.
You know, it hit home for me last night when we went up to visit the patient, and his wife started crying outside the room. She was choking up, and that was meaningful. And I think we did something good for him today. I think we did an operation that will make him feel better and will keep his brain intact, and that we know will last a long time. And so I hope today is just the beginning of many Correx cases and a new beginning for a lot of patients.
Well, it's been a real pleasure not only to get to know the surgeons here in London, but to see how receptive they are to our suggestions about how at least we've done the operation and all. They seem very eager, and they have a patient population just like Jim and I do, of patients who are at high risk for conventional operations. And so it's been very easy to sell them on the idea of bypassing the aortic valve rather than particularly without cardiopulmonary bypass, than doing conventional surgery for these high-risk patients. So it's been a real pleasure to get to know them. They're excellent technical surgeons who, we don't have to teach how to operate. We just have to, teach them the tricks that we've learned through our experience that's made the operation easier.
I've found them to be enthusiastic and just fabulous collaborators. It's been an utter pleasure to work up here. And Dr. Gu and Dr. Kia are both technically superb surgeons, and they had a great team. They obviously had very good support in the operating room today. The anesthesia team and the nursing team, and the fact that this was all worked out carefully ahead of time. Nothing was left to chance today, and I think the success was a result of intense preparation on their part and their team's part. So it's really been fortunate, and I think we're very fortunate to be able to do the first clinical case here in London, Ontario.
And we're both very acceptable to new innovative technology, and we're very also both want to strive to provide the treatment that provides the best result for the patient. And this is something that Dr. Guo has been interested in for a long time and has done a lot of research in this area. So therefore, when the opportunity came that we could use this particular technology on a patient that would most benefit from it and potentially be the first institution to do the first human clinical case, that was an absolute honor and privilege for us to be able to do that. And with the right guidance and being able to have the right teamwork, and the fact that we were fortunate enough that we had a very good working kind of, you can say, relationship, I think was best, kind of like when the stars line up, we managed to be the right institution, to have the right patient, and to have the opportunity to do the first clinical case, and to have the right team to do it. I think that this, without not only myself and Dr. Guo knowing, having had the experience working together, but having the great, you can say, top-notch nursing staff, top-notch anesthesia, and kind of all being dedicated and all wanting to provide the best care for the patient and provide the teamwork. As you saw in the OR, we were very kind of all worked as a team, made sure it was proper communication. So I think there's a combination that we were given the privilege of being the first center to do it, to do the first human, but also I think we're very fortunate to have the right team in the right environment to do it, and I think those combinations allowed us to be successful in doing the first clinical situation case.
If you can develop a new technology that could potentially touch tens of thousands or perhaps hundreds of thousands of lives, that's a big deal.